Just to start, I will explain that MercyAscot, we're the only private hospital involved in the collaborative. We're the largest private hospital in New Zealand. We've got 22 operating theatres, an intensive care unit, coronary care facilities. Our bed number is 179, and we do probably about 200 operations a week, although we can do well in excess of that in our busy times. The complexity of our operations can range from the simple day stays through to complicated cardiac surgeries, neurosurgeries, so we do cover a lot. So the aim for us has been to reduce respiratory depression and oversedation by 25% over the course of this project. So we're auditing 10 patients per week across the cardiothoracic ward at Mercy, the orthopaedic ward at Mercy, and an orthopaedic ward at Ascot, and we're excluding any patients who aren't on opioids. We're looking at sedation, so that's a sedation score of more than or equal to 2, and respiratory depression, which is a respiratory rate of less than 8 per minute or respiratory rate of less than 10 with a sedation score of more than 2. And the patients that we're looking at are all surgical patients on opioids. Sorry, I didn't turn the slide, did I? So some of the things which we've tested, we've done a naloxone audit, so we've looked at our patients who have received naloxone over the course of the year, and from that we've looked through to see if there are any trends or anything like that that we could work and poster education campaign. So we've developed some posters which we've got up on our board, and they're coming out sort of every 2 to 3 weeks, and that started back in August. Through our audits, we've also discovered that our early warning scoring system chart hasn't been as good as it could be. Some of the monitoring is on the front, and that's done well, but anything that has to be turned over and seen on the back is not always completed at all. So we've amended that with a new early warning scoring system where all the documentation's on the front of the chart. Further to that, we've also developed a clinical management of opioids policy, which specifies the timing for the monitoring of opioids, and then we've gone ahead and put a table of that onto the new early warning scoring system. As well as that, we had the sedation score completely changed about a year ago, and now we've implemented an education campaign so that nursing staff will better understand how to use the sedation score and where it's actually located.
You can see the time ticking down, so I won't go into too much depth here. Unfortunately, the graph we have at the moment is just a bit of a snapshot. After our deep dive, we sort of changed the way we were collecting our data, so we do have it all there. It's just a matter of actually going and reformatting it and then adding it to this graph. As you can see, the monitoring and documentation of respiratory rate is more than expected. Pain and sedation is sitting at a pretty constant between 60 and 80%. The arrows are the first two posters which we put out. The first arrow, poster 1, highlighted how many patients had received naloxone at MercyAscot since the beginning of the year. The second arrow, poster 2, discussed the important balance between pain and sedation, because of course we didn't want pain to increase at the expense of decreasing sedation. The third poster, which we haven't got the data for yet, was on how to measure sedation via the sedation score and when to escalate a sedation score to the anaesthetist. So as you can see, everything's pretty much consistent as far as monitoring goes. Nothing has shown a decrease yet, except for our balancing measure, the average pain score. So that's quite interesting. But what we have noticed as part of the audit team is that we were seeing a lot of patients' sedation scores marked as 0, which was alert and awake almost 24 hours a day. So now what we're seeing now is the full scoring system is being used. So it is marked when people are asleep but easily roused and things like that. And I haven't got the graph here, but over there on our storyboard is the percentage of patients scoring a sedation score of greater than or equal to 2, which is showing a slight decline, and that data does go back to May. Okay, this is our graph that shows the number of naloxone cases this year or to the start of October. The number of patients is along the bottom axis, and the little numbers annotated on the graph are the days between events. So 2 days being the closest time between episodes and 44 days the longest. So we're obviously hoping to extend the number of days between events.
Key lessons and achievements. Education around the sedation score has improved understanding, and we have, the nurses all have to go to an annual update day once a year, and we've dedicated our time this year to discussing the sedation score and how it's used, and using scenarios, and that we've done a pre-test and a post-test, and that's made quite a difference to the nurses' understanding, because the sedation score, well, what they were used to using up to a year ago was more around the conscious scale, not a true sedation scale. So we're still doing a lot of education around that, and that seems to slowly be improving. Reformatting the early warning scoring chart seems to have made quite a difference. So when that was first introduced a year ago, all the sedation and pain information was on the back of the chart, and it just wasn't getting filled out. So now it's going to be on the front, and we have trialled that in 2 of our wards, and that's made quite a difference to what the documentation. The policy on timing of monitoring and adding the summary, we're still a bit unclear, because we have done an audit in one of the wards, but that probably required a little bit more education around the changes that we'd made with the monitoring on the back. So, but we have had positive feedback from the nurses that it would be helpful, but time will tell whether that will actually make a difference to documentation and monitoring. Posters have been creating talking points, but we're unclear about how many nurses are actually reading them. Do you want me to continue or stop?
If you wouldn't mind